Welcome to Airway Breathing Conversation, a podcast presented by the anesthesiology residents at the University of Saskatchewan, created to provide individuals of all levels of medical knowledge with anesthesiology-related healthcare information. Join us this week where Shawn Silver, a second-year medical student and prior STARS and ICU nurse with a master's degree in medical education, discusses his unique relationship with medical education and insight into how different medical professionals develop their own skill sets. Now, whether you are an anesthesiologist, resident, medical student, or member of the general public, come take a break with our host, Anesthesia PGY3, Dr. Sebastian Turcott, and a multitude of brilliant and insightful guests as we demystify the incredible specialty that is anesthesiology, one episode at a time.
Hello, listeners. Welcome to another episode of Airway Breathing Conversation. I'm your host, Sebastian Turcott, and we have Dr. Alan Meldrum again producing our show. Shout out to Alan in the back behind the camera. Today we have two awesome special guests. One is a co-host of ours now, Dr. James McCaskill. James is a first-year resident with our program here at the Department of Anesthesia. Hey, James.
Hey, how's it going?
Good, man. Do you mind telling us a little bit about yourself?
Yeah, sure. I'm James. I'm a first year in Saskatoon. I was born in South Africa, pretty Canadianized by now. I moved when I was 8. I did my undergrad here. I did med school here, and now lucky to do residency here as well.
Yeah.
So, yeah.
And we are super happy to have you here at the department. So, and thanks for joining us on the episode today, buddy.
Yeah.
And today's topic that we wanted to discuss was sort of medical training in general a little bit. And we've got an awesome special guest with just a wealth of knowledge and background to help us dive into this a little bit, Shawn Silver. So Shawn, thanks for joining us today. And do you mind telling us a little bit about yourself?
Yeah, awesome. Thank you so much for having me. This is an amazing opportunity. So, I'm currently a second-year med student in Saskatoon here. I'm originally from Prince Albert, born and raised on a small town, born and raised on a farm just outside of the city. Grew up, did my nursing degree in Prince Albert. I graduated in 2012. So I was able to do the whole program in Prince Albert. I did my clinicals and everything in Prince Albert, which was really cool. And then in 2012, that's when STARS came to the province, and I kind of made that my goal. I said I want to do that. So I moved to Saskatoon to gain the tertiary hospital trauma care experience. Worked in Emerge for about 3.5 years and just kind of networked, found out who worked at STARS and followed them around and sucked up to them and networked. They gave some advice to go to ICU. So went and did 1.5 years in ICU and then got on at STARS. Worked there for about 6 years, and now I'm back in school.
Yeah. So Shawn, you also have a bit of a background in medical training itself, right? Do you mind telling us a little bit about that?
That's right. Yeah. So growing up, I did martial arts and started when I was 4, and then I started coaching at a young age. So I just fell in love with teaching and coaching. It just kind of was a part of my life growing up. And so when I got more comfortable in nursing and I knew what I was doing, I took on a bit of as many mentorship and education roles as I could. I got all of my instructor courses and merit badge instructor trainer courses. And there was an opportunity, and then I found that there was the health profession education program at U of S here. I graduated in 2023 from the U of S.
Nice.
With a master's in health profession education.
Cool. And what did that program look like?
It was super cool. It was very practical. Like I was saying, it's through the U of S. So it was kind of handcrafted with a lot of faculty at the College of Medicine. So it was 2 years. It was course-based. 2 years if you do it full time, and very practical. There was a lot of learning theory. There were things like how to make a podcast, how to make a good PowerPoint, how to the principles of doing micro teaching sessions and things like that. So very practical. It was an excellent program.
Okay.
Yeah.
Cool. And how'd you apply that back to sort of your role as a STARS nurse then afterwards?
Absolutely. Yeah. So The cool thing about the program is it was interprofessional. So in my class, there was nutritionists, pharmacists, physio, paramedics, physicians, kind of the works. So it was really focused on just how to be a medical educator. So at STARS, it's a really cool environment where the expectation as soon as you get hired is that you are kind of an educator. We have certain outreach education roles. And again, the expectation is that all flight staff, flight crew also participate in the education and the training. So I kind of fell in love with that, and I got to apply some of the content I learned at STARS through that. And then I also got a job as the mobile education leader at STARS. So really cool program. It was started in Alberta with STARS, and it is a giant simulation lab in the back of a big RV. And we drive it around to communities, park it outside of the hospital, and then the staff come out and run simulations with their crews. So as the flight crew, usually two of us go out there and run simulations, do big debriefs. Really cool opportunities. So it was very, the master's was very applicable to that.
Yeah. Sounds like a wealth of knowledge that you gained that you could just, and in terms of in a practical way, bring it back to work and try to educate others too, both at work and stuff. And Shawn's being really modest, but like he taught me when I was in med school.
Oh yeah,
as a STARS.
I was gonna say you look super familiar. I think you led a session.
For sure.
Me in med school,
so like you were running sim sessions for medical students and stuff. So it's kind of cool to see you in that medical student role now, which is kind of interesting, right? So what has that transition been like in terms of going from a STARS nurse and then participating in the education side of things, and then now you're back as a learner again, sort of in med school. What does that look like?
Yeah, it's been really cool. And if we told my grade school teachers that I was in medical school right now, or that I had a master's in education, they'd fall off their chair, because I really wasn't. It wasn't that I wasn't a strong student, but I just wasn't. I wasn't very passionate about learning. So all through nursing school and stuff, it was like, I'm just 7-0 and go, C's get degrees kind of thing. So I kind of ran with that through nursing. And then I found out that I just absolutely loved it. Right. So as I started learning more and then taking on these education roles, I looking back, I realized how much I missed out at in nursing school and how I just wanted another chance at it. Right.
And what do you think, what switched for you? Was it being in healthcare? Was it just maturing a little bit? Like what switched there that sparked that passion or that love?
That's an awesome question. And I think some of the biggest parts, it was the kind of that glass ceiling. Like I always wanted to know more and do more. And kind of through my martial arts training and then STARS really fostered it was reflexive practices, and just constantly we reflect on every call, every mission. How can we get 1% better on everything that we do? And I think it just, the switch was that, I can get a lot better. Kind of in everything that I'm doing, I can keep getting better and better and learning and filling in those gaps that I had. And I found that for me, one of the best ways to do that was to teach people, because you don't know something until you can explain it in its simplest terms and teach it to people. So yeah.
Very cool. And I always find when I'm teaching something to somebody else, like you almost start to reframe it in a different way in your own head, and then it almost teaches yourself at the same time a little bit too. And almost every time that you're teaching somebody, you almost teach it in a slightly different manner, with a little bit more detail or different context. And then it just starts to solidify in your head a little bit too, which is cool.
Yeah. And identifies gaps that you don't know very quickly.
For sure.
It's humbling.
And then you can learn from the person you're teaching.
Yeah.
Which I find is very interesting in medical education.
Yeah. True.
So I guess James and I are very familiar with the medical education process. You're very unique in that you have insight into both like allied health professional education a little bit and the medical education route. What are some of like the similarities or differences that you've noticed between those two streams of education?
Yeah. You know, I can't speak so much for the nursing program now because, you know, I started in 2008. So I'm sure it's different now. But just from medical school and nursing, it's almost opposite. Nursing school was very, we're going to kind of teach you what you need to know up front, learn the skills, learn the fundamentals, and then you're going to get in there and start applying it in a safe way, learn the skills, get in there, and just it's all about exposure. And then where med school, it's so heavy on the theory. Like I couldn't believe, you know, in nursing school, and maybe this is again because I wasn't a super strong student, but like I didn't really get a grasp of what ischemia was until fourth year. It's like, oh, that's what ischemic chest pain is. That's what's happening.
Yeah.
And then you flip back and it was like the first day of school and the pathology lesson, they came in and started talking about tissue ischemia. And I was like, oh my goodness, I can't believe they're talking about this already.
Yeah.
And they just throw you into the deep end.
Yeah.
And I think this is kind of my impression. I don't know if this is actually what it is, but it seemed like with other programs, they teach you a little bit and they say, we're going to teach you 10% of what you need to know, but we want you to learn that 10%. And then we'll add on. It'll be incremental exposure. Where I feel medicine is like, okay, here's 80% of what you have to know to be a physician. We only expect you to know 10%, but we're not going to tell you that. We're giving you 80% right now. And it's just, you know, so the expectation isn't that you know everything, but they're telling you it all.
You almost get exposed to it multiple times is how it was explained to me. Like the medical school curriculum is not cyclical, but you know, I guess in a way it's cyclical where you're going to see the same thing multiple times. And then with every time that you see it, whether it's cardiac ischemia or other clinical presentations, every time you see it, the more you're going to pick up on it until you finally sort of understand it in a way. Yeah,
absolutely. And that's kind of the big difference is I think other programs kind of do it still is that a little bit of that introduce, reinforce, master kind of approach. But they're adding knowledge as you go, where I feel like, again, medicine, it's like, oh no, we're introducing you to it all right now, you know, and then it's that continuous exposure, but they just keep showing you the same thing over and over again. It's like, oh, it's starting to sink in, starting to root in. Cool. Yeah.
Did you feel like your approach, obviously there was a lot of growth for you from what I'm hearing in your journey, but did you feel like your approach to learning had to change a lot between nursing and medicine, or was it just that you became more familiar with studying?
Yeah, I think it's kind of challenging. Like I don't remember studying a whole lot in nursing school. It was afterwards, like after I got out, and you know, I was keen. I was out there and I was like sought out learning opportunities when I was on clinicals and things. So I picked up on the fly quite well, but there was still a lot of things that I didn't know or couldn't pick up on, and I needed to start studying. And I recognized that pretty quick. So it was a lot of self-studying, I guess. And then through nursing and you know, there's so many continuing education things and advanced certificates and advanced training and all those things. So I was able, you know, like I got the certified flight registered nurse, which it's through an American program. They don't have it in Canada here, but you know, it was like 3 months of just straight studying to go do this kind of board exam. But that wasn't protected time for me. It was in the evenings on my lunch breaks. I'd be going through flashcards and stuff. So now that I have this dedicated time to be a medical student and study, I've had to dial back a little bit because I was so used to being like, okay, I have time right now, so I have to study. Yeah. And it's like, oh, that time is actually 8 hours. I don't need to be doing this much right now.
Okay.
Yeah. Now, sounds like the time management skills are really crucial sort of through your nursing education, and when you are seeking that continuing nursing education or those certificates, sounds like you were doing it on your own time outside of working at the same time. Yeah, what was that like?
Yeah, it was challenging and so even for things like the MCAT, like so my when I did the nursing program, it was direct entry, and I have never taken a university level chemistry class or physics. I still don't really get organic chemistry. So but I, because I kind of put my mind into doing this. So I was like, I got to do this. So I self-taught myself all those things and got all the prep courses and all that stuff. It was kind of good timing because it was during the pandemic. So I didn't have anything else to do. So when I was on shift at STARS, because I was full-time there at that time, and then I was still doing educational, because I was the mobile education leader, I couldn't go places. So I did a lot of virtual presentations and stuff. But once I made the presentations, they were I could just kind of copy and paste them and present them. So I had a bit more downtime to study when I was at work, which was really fortunate. So yeah, that was, looking back, it was still quite heavy because I was working, especially during the big waves of the pandemic. I would have been picking up extra shifts. I was helping in the hospital. So I was working in Emerge and ICU still. And then studying for the MCAT. And then that was when I started my master's as well. So I did the master's during that time. So yeah, the first couple months of med school, it was a very surprising break. Like being
interesting.
Not
you don't hear that often.
Yeah, no kidding.
Not having to do shift work anymore and having weekends off and stuff. It was actually a really nice shift for me. Yeah.
And so, Seb, you were saying you had taught med students though as a STARS nurse, right, Shawn?
Yeah.
And so, what was it like teaching medical students then versus being a med student now?
Mm-hmm.
What are things you noticed as an educator there and being in your position now?
Yeah, it's so just a bit of that background. So we had an opportunity to teach, like I was a ACLS, like heart and stroke instructor. So I got to teach some of those courses, and then most of my interactions were with the point of care ultrasound. So again, in that moment, it was mostly just the first and second years, and then there was the occasional R1, R2, kind of the rapid programs. So the training that we had was very much like, okay, this is critical care resuscitation. You're on the scene of an accident. What are you going to do? What are you going to use your ultrasound for? So we were kind of teaching the skills in that very focus application of it. And then when we would be applying it and trying to teach it to medical students, there was a lot of but why? Why? And I was like, just learn the skill, please.
Right.
I'm just teaching you the skill.
Right.
You need to just learn how to hold the probe first. And at the time, and some students, it wasn't uncommon for them to. It was kind of evident that they hadn't prepared, and I would just be frustrated. I was like, they're med students, like they're going to be doctors. How can they do this? But now that I'm in the weeds and on the other side, it is so challenging. Like some of these clinical skill sessions are topped on right before an exam or something, and people are showing up with an hour of sleep, and it's like, I get it now. I get why they didn't have capacity to be 100% prepared. So
yeah, the trying to, I guess that is a different topic on time management skills, I guess, a little bit in terms of trying to manage your study time in med school. But to go back on, the question of why a little bit, it almost sounds like, again, it goes back to that theory-based education approach versus a practical approach-based education, right? Would you sort of agree with that?
Absolutely. And I think there is still a time and a place for it.
Yeah.
Right. Some of the feedback just from peers when we're teaching like the advanced cardiac stuff, students just want time on the probe. Like they just want to scan the heart.
Mm-hmm.
But if there's a finite amount of time, we have to teach them the how and the why. And I think it all depends on the student about what their approach is. And I don't know what the best way is. I learned backwards.
Mm-hmm.
So I'm learning different than all of them. I found it very easy to just learn the skill and then start applying the background knowledge.
Right.
Where, like I said, I think medical school is just backwards. You're learning so much of the background and the knowledge.
Right.
And then the skill development comes after.
Interesting. Yeah.
So it's very opposite.
I guess that touches on what kind of a learner you are a little bit, right? If we take ultrasound, for example, some might want to understand the theory of ultrasound, how it works, how do you apply it in certain clinical settings before you actually start probing or scanning people. Whereas I think I'm more on the practical side of learning a little bit, where I just want to learn the
Mhm.
skill first. I want to be
Mhm.
able to obtain that image. You know, if you're scanning a heart or a liver, looking for free fluid in the abdomen or something without getting too technical. But then after that, understanding, okay, what am I looking at? What is this image actually showing me? And how can I apply that in a clinical setting? So I think that brings up a really good point of understanding what kind of a learner you are and then tailoring your learning objectives to whatever session you're in.
Absolutely.
Mhm.
And like I was saying, it's just so different because I spent so much time as a nurse in my background where it was, again, we didn't have to know and we didn't need to know all of the deep patho and all of the mechanism of actions of all the medications. So I had time on the job to be exposed to it and slowly learn about all these things.
Mhm.
And now that I'm in school, now I'm able to really dive in and be like, yeah, but why? Like I can see the patient, I can see the medication that we're giving. I know the indication, I know the side effects, the presentation of the patient, but why? And just in talking to my peers, I think I really take that for granted, is just having that, I guess, like a schema, having that file folder where I can go reach out and pull out a patient, be like, oh, this is what I'm applying this concept to. Because for lots of them, they've never had that exposure. So it's really challenging.
Mhm. Yeah, it's sort of touch, and then that is like almost experience-based learning, right? Where you learn about a theory, but then you can tie it to an experience that you've had in the clinical setting, and it almost helps reinforce that learning a little bit, that theory.
Yeah.
But if you don't have the theory beforehand, then it might be tough to, again, the why. Why am I doing this if I don't have the theory beforehand? So you have a really unique background in that I find in healthcare, we work as a team, but every team member has a different background, different level of training, different areas or places where they've trained, where they do things differently. And that team is expected to work cohesively, sort of in an acute situation in the emergency department or the OR, something like that. And how do you find, knowing what you know now, like how does that affect team dynamics a little bit when people are trying to work together, but they all come from different backgrounds of training?
It's always delicate, and it does really take a lot of exposure and practice.
Yeah.
And that's where I think simulation, obviously I'm biased.
No, that's
I
great.
love
Yeah, we
sim,
can talk
but
about that.
simulation
Yeah,
is
yeah.
absolutely
Yeah.
the key to it all. And when I was like, we had a sim mannequin, but it was like in a closet at my school. But I think they use it a lot more. But I think prior, like years ago, it was just exposure. And that was where, when I started in emergency, I was, because I did my final practicum in Emerge, and they were doing an ACLS course at the same time on one of my days. And they're like, go do the course. And I ended up like passing. They wouldn't sign me off. And they're like, we'll hire you in Emerge. We never do this. And I was like, but at that time it was even, we don't hire new grads in Emerge at that time. And that would have, 12 years ago. And then when I moved to Saskatoon, you've only been a nurse for 6 months. We only hire people with 2 years of experience. And then you go to, you have to be Emerge nurse for 5 years before you do trauma. And, but now that's starting to go down, and, that time frame, just because of the system that we're in, it's going back. But I think where I'm going with that is that experience, that job experience, experiential learning, that sets up the recognizing different roles and respecting team dynamics, where it's kind of shifting away from that a little bit now because of the way, again, the way the system is. It's just people aren't able to have that experience before being kind of chucked into those team roles, right?
Yeah.
And it can impact the team dynamics and the workload, and then the sequelae of bad experiences and potential bullying and adverse events and things, and that trauma that people don't maybe appreciate. So I think that is really important to be doing these multidisciplinary simulations where you can work with other people and recognize their strengths and recognize their utility and their roles, because it really is amazing. Like, again, I'm a big proponent of like nursing and paramedics. And there's still, and I'm not, some of my peers are like, oh, as a STARS nurse, like, have you ever seen a stroke patient? Have you ever dealt with this neuros? Because we were doing neurology, and like, oh, do you see a lot of strokes? I was like, almost every day we did a stroke alert, we'd transport them, right? Like that was just what we did during the cardio. Oh, how do you guys do ECGs at STARS? And I'm like, oh yeah,
you guys have read a few of those.
Yeah, that was a part of my job, as I used to teach ECGs. So I think it's really important to invest time in learning about other professions and their strengths and what role they play. Even though it's not always obvious, their knowledge and experience is working in the backgrounds to make things smooth. And we just don't see it because things are going smooth.
And you find maybe like simulation is a great topic, and it's something that we're doing a lot more of nowadays. Is that something that's evolved sort of through your healthcare experiences as like a positive that's helped everybody understand those team dynamics a little bit more?
Absolutely. And like I was saying, I really didn't have much exposure with it before. We would do our ACLS and PALS and stuff, with like a CPR dummy on the bed, and you run through your scenario and just kind of, oh yeah, I'd put oxygen on, and I would, I'd put an IV in. Mm-hmm. And then when I was trying to get on at STARS, I had some really good mentors who were staff there, and like, oh yeah, you have to do a simulation to get hired on. That's a part of the interview process. You have to do 2 high fidelity simulations. So, and that was so different for me. It was an amazing experience, and it forced me to learn and grow. And especially at that time, because we didn't have the training, and they said, you're going to take on the role as a team leader, as if you were a STARS air medical crew. Go. Like, I don't know what succinylcholine is. Why do you want me to do this? But that really kind of springboard into simulation, because that was, again, it was the part of the hiring process. The STARS induction training is 6 months of very like sim, main testing sims at the end. Like that's how you get hired and signed off and pass academy. So then with the mobile education unit, with the sim bus, bring that out. And it was, we're not going to come unless you have some physicians signed up, kind of thing, because it is so important to see the physicians in a vulnerable state as well, and see that they're human and they're thinking about things and they know when to ask for help, but also seeing how much they know. Yeah. And then for them, seeing the nurses work through things and seeing the amount of work that they have to do to get an infusion pump set up. Right. And I think,
we take for granted how easy it is to order something and then just expect it to be ready.
Yeah, totally. And that was a big part of it too. The medicine was one thing with simulation, but the biggest part was communication. Yeah. It's so huge. And I wish there was more. I know there's only so many opportunities. But in med school, I wish we could be doing sims every week. Like I love it.
And do you think it's a frequency thing? Do you think that's the main thing? Like we should just be doing more sims in general?
Yeah. Cause it is, it's uncomfortable. Even for me, like I simmed all the time forever, and I ran sims. And now when I'm simming as a med student in the sim center, it's new people, it's new faculty, it's new expectations. They have a new way of doing things. Like at STARS, we might say, okay, I'm listening to the chest. What am I hearing? Because we know the mannequins kind of suck. So we're like, what am I hearing? And here they'll be like, what are you hearing? And I'd be like, oh,
we have some very high fidelity mannequins here.
I get feedback, and it's like,
for sure,
you should be putting more. And I'm like, it's just a different environment, different dynamic. So they do a really good job of creating that safe space and letting you figure out the simisms, so to speak. But getting over that hurdle of learning how to sim is probably the biggest hurdle. Then you can start getting the real educational value out of it.
Yeah. Once you just accept that this is a learning experience and that mistakes are okay, I find you sort of get over that hurdle a little bit. And then it just allows you to learn a little bit more from the scenario. And I guess this is just a perfect time for a shameless plug that our anesthesia residency program does lots of simulation, and it's super high fidelity and really good learning experiences for our program and our residents. So
I think we're one of the programs that uses the sim lab the most, isn't it?
Yeah, I think so.
Us and Emerge.
We're there quite a bit. Yeah. It's great. Yeah. And like you said, Shawn, it just gives you so many more opportunities that you just can't learn from a textbook. Those communication skills, the thinking on your feet kind of thing, the practical skills that you have to think about, and the teamwork, aspect of things. Yeah.
Yeah. And I think that's why it fits so well, like STARS. And then, the specialties like anesthesia and emergency, where it is like, it's high stakes. You have to be thinking on your feet. You're in charge of a team. You have to know your stuff in that moment and do it in a skillful and tactful and productive way. I think that's what draws me to these areas as well as in medicine. So, I think it's just my comfort with these the resuscitations and simulation. Just kind of playing with sim.
Very cool. Something that we notice sometimes is as anesthesiologists, our role isn't always very clear to some people in terms of what we can provide in the hospital and stuff like that. Given you've been involved in so many acute situations where anesthesia has been involved as well. What do you think are some of the ways that we could better educate other allied health professionals on, what our role is in the hospital, so that it can be a bit more of a cohesive team?
I think it's so interesting because even when I think back, I didn't work in the OR, but we got to do OR time in Prince Albert, and I had no idea what the anesthesiologist did. Like if something happened and they crash, all of a sudden this enigma came out from behind the curtain and just took over the show. And I was like, who is this? What's happening? So I think from the get-go, it'd be beneficial for any medical education program to have that kind of early exposure with each discipline. Kind of having those kind of mandatory sessions on what is that profession, what is their role. And I don't know this at this time, but kind of those like internal medicine kind of fits into a bracket of professions. And then emergency and anesthesia, I think they're kind of, even though they're quite different, they kind of go in that resuscitation realm, right? And it'd be nice if there was more exposure about what that is. Like what is not necessarily critical care, but practitioners who have the capacity to do critical care when they need to.
Yeah.
If that makes sense.
Okay.
So I'm curious with your master's, we talked a lot about sim and that experience as a STARS nurse, but have there been any things like from your master's that you've really taken away and applied now as a med student for teaching too, outside of this experiential learning that we've talked about?
Yeah, that's a great question. And it's being on the other side of the fence as well, where it's when I see educators and physicians doing things really good, I'm like, oh, I learned about that. Like, I never, because I finished my master's in the spring and then I got into school. So I used my master's as I was going and I was teaching, but I didn't really get to apply it. So I hate that it's like I'm losing some of it already, but seeing them, it's like, oh, I learned about that and they are doing it perfectly. Like this is textbook what I learned. Or there's things where I'm like, oh, we were kind of showing never to do that. And this is why, because it's making me feel in a bad way. And this is what that textbook was saying it would make me feel like. And I feel like that as a learner right now. So it's given me a lot of insight into, and again, I love reflecting and looking back and like, ooh, I did not do that debrief really well. And I stood my ground and I complained about that person being upset in the way I gave them feedback. And now looking back at it, I'm like, that was horrendous. Why did I do that to them? So it's been really, it's been great for me to kind of see what to do and what not to do. And then being able to, again, apply it back to things that I've done and things that I think I did okay and did well. And then things that I definitely could have done differently.
Yeah, cool. Debriefing, you bring that up. That's a really important aspect of our training, I think, that we take for granted is when we're in an acute situation and there's a lot going on, to be able to step back after the fact and debrief a little bit. What, I guess, in your world, like, what makes a good debrief? Like, what are aspects of it that are important to focus on?
Yeah, I guess from two, as a provider, as a clinician in the moment, being a member of that team and recognizing that, it doesn't matter if we don't like each other and we don't get along super well. We were there with the shared common goal of being a good provider. And it was, as cheesy as it sounded, it was patient-centered. We had a shared goal, right? Let's debrief what went well, what didn't go well. How can we get better to provide better patient care? And there are times, on calls where we would getting yelling matches as we're restocking the helicopter, and like, you told me to do this. And then we go, but it would force us. And it was that culture where we would go look it up after and be like, you're right. We should have been that. So I think it's just really being humble and being open, because you can learn something from every interaction, everything. From simulation, I think it kind of is the same idea. The goal is that we're learning something from this experience. There's really, really setting up that safe learning environment and that safe space. And this is something I think I've really come away over the last couple months, especially. I've been really focusing on it, is really giving people the opportunity to feel valued. And I think it is actually, it's simple, but it is a bit of an art. Because I've been in some situations where either in a sim debrief, or I'm shadowing, or getting feedback after a simulated patient scenario, and they disregard, they don't ask for any experience, and they started being like, okay, well, this is a stethoscope. I'm like, don't waste my, let's get into it. Like, tell me more.
Right.
We're setting it up and saying, okay, what are your backgrounds? What were your degrees? What were your undergrads? Do you have any experience in healthcare? Are you familiar with this before? Have you ever seen this? And just priming people with that, it gives people the opportunity to say, no, I've never heard of this or seen it before. I'm a clean slate. Let me, give it to me. And on the flip side, it can say, oh yeah, I do actually have some experience with this. This is what that experience is. I do have some gaps here. I'm comfortable here. I would like to focus my learning and debrief on this if possible, and kind of centered it.
So like, as a learner, having the feedback meet your learning objectives almost a little bit, and then it provides more value in terms of what you can take away from that session.
100%. Yeah. And on that, it's creating that space where I don't need to feel like I need to prove myself, where I can say, oh, you recognize me and value me.
Yeah.
I'm okay. I don't need to prove anything to you.
Meeting somebody where they're at, and then being able to supplement where they're already.
Yeah.
And then raising above that a little bit.
And there was, there's been quite a few good experiences, but one was, I was shadowing anesthesia, and they were putting in LMA, and it was an ortho, so the patient was sitting up. Said, do you want to put this in, or are you not allowed because you're a second year? Like, I'm not sure. I was like, I'm not actually sure, but I have. Yeah, I was like,
You've done that before.
Yeah, I was like, I've put a ton of eye gels in, and I've intubated people, but I've never actually put an LMA in, let alone sitting up. And they're like, is that okay if I just show you right now and walk through it? Absolutely, that's great. Where if they had said, okay, I'm going to put an LMA in. This is what an LMA is. This is the I would have been like, get out of my way. I'm going to do this. Like, just give it to me. I'll do it.
Yeah.
And that's not really a good environment. Right. It just creates that safe space for me to say, I don't know. I know a lot of, and another, it was a clinical session with a nephrologist, and again, he was awesome and introduced himself to everyone and said, what are your backgrounds? And he got to me and said, I know you from somewhere. And I was like, I think I worked with you in ICU. He was like, that's it. But then he went on and said, intelligence is contextual. So, I can't tell you much about ortho. I'm not intelligent in the realm of MSK, but they wouldn't be able to come in here and be intelligent in nephrology, right? Like it's all contextual. If I want to intubate somebody in the back of the helicopter, that's your strength. Talking about dialysis, that's why you're here to learn. And again, it just made me feel like, oh, I'm not stupid. I am intelligent in my context.
Right.
It's just, this isn't my context right now.
Yeah. And if we loop that back to the team dynamic, then having everybody apply their strengths in a team sort of scenario almost, lifts the team forward, and then everybody's able to, again, give it their all and contribute to hopefully a positive outcome when we're in the clinical setting. So
And that was a big learning point when I used to do some of the teaching stuff. I'd go out and these rural physicians, they're chucked into the middle of nowhere in these, and some of them, were pediatricians or hematologists, or one was a ENT surgeon, and they're acting as a family physician covering the emergency department in the middle of nowhere. And then they get on a phone consult and they aren't giving, the best critical care report.
Right.
And we're like, oh, can you believe this, doc?
But it's just not their background.
That's not their background. They and that was kind of what I learned, and I started priming when I would do teaching sessions. Like, as critical care transport, we know a ton about a mile deep of an inch wide river. The saying is where these providers know.
Right. That's an interesting
miles,
metaphor that I haven't really thought of.
Yeah.
We know a lot about a little subset. And that's, again, it's not that I need an ego boost, but when it happens often where people disregard or discredit past experiences, because, we have pharmacists in our class and physio and a couple nurses and stuff, and discounting that experience, it makes you feel like, I know this stuff, like, let me prove, let me show that. But then the next thing is like, how can they expect me to know that? I never learned that before.
Yeah. Oh, interesting. This has been a super interesting conversation, Shawn. Thanks for joining us. It's, I think, really cool to get your background in terms of both the nursing and allied health professional, now this side of medicine that you're continuing to move forward in. So thanks a lot.
Yeah. Thank you so much. And yeah, such a cool opportunity. And that's just all I want to do. Like, I love coaching and mentoring, and it's, this is just another
you can really
way.
see your advocacy sort of come out for learners and educators alike, which is cool. So
yeah. Thank you.
Yeah. Thanks for coming, Shawn.
All right. Well, James, thanks for joining us today.
Yeah.
I'm sure our listeners will be hearing more from you too in the future, hopefully. Thank you again, everybody, for listening. We're going to sign off for now, and we will talk to you next time.
You've been listening to Airway Breathing Conversation, a podcast hosted and presented by the anesthesiology residents at the University of Saskatchewan. Please note that while this podcast is run by healthcare professionals, it is intended for educational and entertainment purposes only. We are very thankful to our guests for taking the time to share their wisdom with us this episode, and a very special thanks to you, our listeners, for tuning in. Don't forget to follow us and our associated USask Anesthesia accounts on social media. You can find all our social media links on our Linktree page at linktr.ee/abc_podcast. You can also find the department's social media links on their Linktree page at linktr.ee/usask_anesthesia. We'll see you next episode, but until then, stay calm, take a breath, and always remember your ABCs.